السلام عليكم. أول حاجة طبعا أحب أشكر الأستاذ دكتور أحمد عثمان President of SWARS and دكتور أحمد المصري Head of the Scientific Committee على دعوتي للمشاركة في الSWARS اللي بشارك فيها بأكتر من 20 سنة، وأحب أشكرهم طبعا على تقديمهم لي. Our talk today is about future of glaucoma management. I think most of us here treat glaucoma, and most of us agree that the kind of care we give to glaucoma patients now is not ideal. I hope in the near future, with the advances in glaucoma management, we can give better care. These advantages include advances in diagnosis and advances in treatment. Advances in diagnosis include areal detection and risk prediction. This is done by advances in imaging, like ultra-high resolution OCT, OCT angiography, detection of retinal ganglion cell damage before visual field loss, and AI algorithms for identifying eyes at higher risk of progression. AI, as we all know, artificial intelligence is now a part of everything we do. In glaucoma, it can help in automated optic nerve assessment, OCT interpretation, visual field progression analysis, prediction of future visual loss, and personalized targets for each eye of the patient. There is breakthrough in tonometry. We all measure intraocular pressure in our clinic once or twice a day, but we all know that IOP peaks occur at night or early morning. There are two methods for continuous monitoring of intraocular pressure. First is the triggerfish microsensor. It's a non-invasive wireless soft contact lens designed to take automated readings. It measures spontaneous dimensional change of the eye at the corneoscleral junction to record the IOP-related profile for 24 hours. Also, there's another advance in tonometry is eye-mate suprachoroidal sensor. It's implanted in the suprachoroidal space as a standalone procedure or during other glaucoma surgeries. We have advances in visual field testing, usual visual reality. It's a headset visual field perimeter. It performs several eye tests without the need for special patient prep like eye patching or environmental conditions like dark room. Now, as regards the treatment, we have advances in medical treatment, we have new laser procedures, and we have new surgeries. The medical treatment, we have advances in two ways: sustained release drug therapy, which we call dropless glaucoma treatment, and you have new anti-glaucoma molecules. Sustained release drug surgery, they are either non-surgical external modalities or surgically implanted devices. Non-surgical external modalities include Eyenovia OptiJet dispenser. It's an easy and accurate way to dispense eye drops, especially for old people with difficulties in movement. We have latanoprost or travoprost delivery versus via punctal plugs. We have medicated contact lenses. Two drug-loaded contact lenses are currently under investigation. One is the latanoprost-loaded contact lens, and the other one is the preservative-free bimatoprost-loaded contact lens. Surgically implanted device, we have Durista, which is bimatoprost injected directly into the anterior chamber. We have the iDose, is a tiny titanium implant designed to release travoprost in the anterior chamber continuously. We have also intracameral injection of latoprost called OTX-TIC. A novel drug for formoterol is used to be injected intravitreally. It usually works for 6 months. Also, we have a spyglass. It's a intraocular lens implanted after cataract surgery with multi-year prostaglandin elution. That's for how to deliver drug. Now we're going to speak new anti-glaucoma molecules. Of course, we are all hearing about the Rho kinase inhibitors. They increase trabecular outflow and lower episcleral venous pressure. They reduce intraocular pressure by 20–25% and are especially effective in normal tension glaucoma. We have nitrous oxide donating prostaglandin. It's a latanoprost bound. It increases trabecular and uveoscleral outflow. It has a double mechanism that reduces intraocular pressure from 30–35%. We have combination like ROC and prostaglandin combination. It has multiple outflow pathways. It reduces intraocular pressure by 30–40%, and it is very potent. We have latanoprost bunit, which is called Visulta. It's a nitric acid donating prostaglandin, and it also has two different pathways to lower the intraocular pressure, and other drugs. Now, why we all think that our treatment with IOP lowering drops is not ideal? Because poor adherence. It was found that about 20–80% of patients are non-adherent with topical drops. We all know that the chronic preservatives like BEC leads to surface inflammation, reduces tolerability and surgical success. A subset of patients keep looting retinal ganglion cells at normal intraocular pressure, and we are not giving any neuroprotection. So what is beyond eye pressure? We have neuroprotection, we have neurodegeneration, and we have gene therapy. Emerging therapies aim to shield the retinal ganglion cells and optic nerve directly from cellular stress and excitotoxicity, preventing them from dying regardless of pressure levels. Historically, and we are still seeing, it's not historical, it is present. We always tell that the patients, what you lost from glaucoma is permanent. However, cutting-edge clinical trials, such as those utilizing ciliary neurotrophic factor, stem cells implants, are demonstrating the potential to repair, rejuvenate, and actually restore damaged nerve cells. Gene therapy, it's used to reprogram damaged optic nerve cells back to a younger state to encourage tonal regrowth. And also there are studies to alter how supporting cells astrocytes react to disease, turning them from harmful cells that accelerate nerve damage into protective cells. We have new laser procedures like direct SLT. It is a rapid non-contact automated procedure performed directly through the limbus without gonioscopy. Studies showed that DSLT is safe and effective. We have new surgeries, mix of all we hear about. We have Schlemm's suprachoroidal implants like iStent and Hydrus. We have suprachoroidal space implants like CyPass and iStent Supra. We have implants that bypass physiological aqueous drainage pathways like Zen GelSent and PerserFlow microshunt. Sion is a new device used to excise trabecular meshwork during surgical procedures. So, what is the summary to the shift? We are shifting now, or I hope we see it in the next few years, from traditional care to future paradigm. In the traditional care, what we do is reactive management, waiting for progression and then start to treatment. In the future, early aggressive defense. At the time being, we're using daily topical drops. In the future, we'll all be using sustained release implants, set and forget. Now, what we give the patient is strict intraocular pressure control only. In the future, neuroprotection and nerve regeneration. Now, sporadic in-office testing, we have now continuous AI-driven home monitoring. So, the treatment algorithm for the next decade in glaucoma management, we have detect and stratify by AI imaging and risk model, control intraocular pressure without the traditional drops. We have drop-free implants, SLT, which can selective laser trabeculoplasty, we can use it earlier, and mix. We can protect the retina and ganglion cells and their axons by metabolic and gene-based reduction. And lastly, we can restore what is lost by cell axon regeneration. Still, it is not that easy. There are still something that stands in the way. First is cost and reimbursement, durability and retreatment, endpoints behind intraocular pressure, and lastly, learning curve and equity. Thank you for your attention.